You're listening to the Animal Heartbeat. My name is Kieran and Jose.
Hi, and I'm Jose Nogumatos. This is the world's only podcast dedicated to veterinary cardiology.
Hello, everybody, and welcome back to Season 3 of the Animal Heartbeat. Thank you so much, as usual, for joining us.
We are truly excited today to have with us Professor Sydney Möise. Professor Möise requires no introduction, really. Everyone that has ever read a cardiology article or textbook have come across with her outstanding work. Professor Möise is a CV Starr Professor Emerita of Cardiology at the Cornell University College of Veterinary Medicine. Professor Möise is double-boarded by the American College of Veterinary Internal Medicine in both internal medicine and cardiology. And Professor Möise wrote one of our Bibles, one of our reference textbooks in cardiology. Sydney, thank you very much for joining us today. It's a great pleasure to have you with us.
Thank you so much. It's an honor, and I'm looking forward to this. It will be fun.
Sydney, I hope you don't mind me saying, but the
Yes.
Fox Sissons and Moyes textbook is honestly, it's like gold dust in the UK. It's so hard to get hold of. So if you have any copies lying around, you could make some good money on Amazon, is all I have to say about that.
That's true. Yeah, exactly. I once tried to buy it on Amazon, and it was like £2,000, something like that.
Oh, that's crazy. Well, it's a very old book. I'm trying to work on one right now that I'm doing on long-term electrocardiographic monitoring and treatment. And I'm going to be using a lot of the technology that my son has created to really look at rhythms differently than we have in the past. So I'm excited about doing this new, more modern book.
That's very cool. And this is something we really want to discuss with you a bit later on about what you are doing on machine learning and with your son and so on, because in the previous podcast, we have been discussing about AI and the future of cardiology and the effect of what AI will bring. Something that's very exciting that you have described some time ago is inherited ventricular arrhythmias in German Shepherd dogs. This is such an interesting condition, and we would love to discuss this with you. So just for the listeners that may not be aware of this condition, Professor Möise described a quite unique form of ventricular arrhythmias in young German Shepherd dogs, where dogs have structurally normal hearts, but are affected by severe malignant ventricular arrhythmias. If you don't mind, Sydney, could you tell us, when did you first identify this condition? And then tell us a bit the story. How did you end up doing a research colony of German Shepherd dogs with inherited ventricular arrhythmias?
I am very happy to tell you this story of long ago, but even though it started long ago, there are others, and we have also recognized other breeds that have a similar story. But the way the story began with the German Shepherds were just on a regular clinical day. I saw a woman who bred German Shepherds, and she was in distress because she had sold the puppies, and she had 4 different people call her all within 2 weeks saying that their dogs had died in their sleep suddenly.
Wow.
And this woman was very motivated to figure out what was going on. And so we worked together for a number of years. She was breeding dogs. I was testing them. We ended up studying more than 500 German Shepherds. We did trace that it's inheritance, although we never were really able to specifically pinpoint a gene. You have to realize that this was done a good many years ago. If we'd seen it today, we probably would have had much more progress. However, we did make a lot of discoveries with these dogs. When we did do some outcrosses to other breeds, we would get some affected dogs, however, not as great in the number of ventricular arrhythmias. I also want to emphasize that although there's attention given to the fact that they will die suddenly during their sleep, There are many dogs who were affected but never, ever recognized. And that is because in order to find it, you've got to do the 24-hour holters when they are young, less than a year, and you've got to make sure that you get it when they are sleeping for the most part, because most of the mildly affected dogs will only have arrhythmias during the night, and they don't have that many. However, even if they have a few ventricular ectopic beats, they can still produce puppies, if they are in a breeding program, that may be severely affected and die suddenly. And I'm sure you're probably aware there's been a recent manuscript looking at some other young dogs that have a similar finding. Also in the Rhodesian Ridgeback, some sudden deaths due to arrhythmias. So there's something going on with some of these young dogs that's inherited, that's affecting them and having the arrhythmias. I could, in a moment, perhaps if you can let me know if you want to understand a little bit more about the mechanism of the arrhythmias in these animals.
We would, absolutely. I think just to pick up on one thing you said, every time that I've seen these in the clinic, they have been incidentally found arrhythmias, and they have always been found by the primary care vet who has anesthetized the dog for some reason or another, often neutering. And then when the dog's anesthetized, they've seen these horrible, terrifying looking arrhythmias and then referred to a cardiologist. So in terms of the mechanism underlying this, what's the current thinking? What's your current understanding based on your research over the last few years?
The way that it exposes the arrhythmia is when the heart rate slows, as well as if there are other triggers happening. In particular, if there are moments when you have a sympathetic surge at the time you have high parasympathetic tone. An example of when this happens is during REM sleep. This is when we saw the most severe arrhythmias. Also, when the puppies would have exercise and then quickly rest, the sympathetic tone is still high while the parasympathetic is coming on board. These are two particular situations where both arms of the autonomic nervous system are high, and this is when the arrhythmias would happen to the greatest extent. We found that the arrhythmias were primarily originating from the Purkinje system in the left heart, and they were triggered from EADs, or early after depolarizations, and DADs, or delayed after depolarizations. Now, we do not know whether or not these triggering ventricular complexes were responsible for any of the follow-up VTAC, because just what starts an arrhythmia as the mechanism may not be what sustains it.
Right.
That's so interesting, because we are way more used to think about exercise, high sympathetic tone as a trigger of ventricular arrhythmias, right? Sudden death in young athletes, exercise-induced arrhythmias. We're way more familiar, and we generally, I believe, as clinicians, we think more about high sympathetic tone as a trigger of arrhythmia. So it's really interesting that in this case, the arrhythmias are more likely to happen during bradycardia or a pause. Can I just ask you, based on that, because you mentioned the Rhodesian Ridgebacks, and there's been some data now on long QT syndrome. So in humans, my understanding is that patients with long QT syndrome would be more likely to have arrhythmias and triggered arrhythmias during slow heart rates. But your Dobermans, your German Shepherds had normal QT, right? This is not a long QT syndrome. Is this correct?
That is correct. It is not a long QT syndrome. However, it is still classified as a repolarization abnormality. These dogs did not have what we call repolarization reserve. And as you know, when you have a slower heart rate, the repolarization time is longer. And these dogs, we identified numerous abnormalities with regards to the ion channel function during those for repolarization. For example, there was, in these dogs, they had reduced IKS. That's the potassium channel. That's the slow activated one, which is more prominent when the heart rate is slow. These dogs had abnormal calcium dysregulation with regards to the sarcoplasmic reticulum. So they ended up having more calcium sparks, which can occur during repolarization. And these would trigger DADs and EADs. These dogs, we could also get the arrhythmia expressed to a greater extent whenever we gave them phenylephrine. So if we had a dog that on a halter had only a few PVCs, if we gave that dog phenylephrine, which is an alpha adrenergic agonist, it did two things. One, it slowed the heart rate and gave us that component of the formula to getting the ventricular tachycardia. But phenylephrine also will decrease IKS. It will also affect calcium intracellularly, and it would have the ability to increase the probability of EADs and DADs, which then would trigger these dogs into their arrhythmias. Another very important thing is that these dogs also had abnormal IK1, which is responsible for the very first part of repolarization. So you see, I've mentioned numerous abnormalities in repolarization in these dogs. We don't know what the mutation is, but clearly there is something going on with either the regulators of some of these ion channels, the signaling. We just don't know because we never reached that point with these dogs. An important point to also remember, two things. One, ion channels in the heart, in the dog, just like in people, are not fully developed when the puppy is born.
Right.
It may take up to when they're 4 months of age. The development of the ion channels, particularly certain ones, is highly dependent on normal innervation of the sympathetic system to the heart. And we found that in these dogs, the sympathetic innervation to the heart was abnormal. It did not occur like a normal dog. The dogs maintained a neonate type of innervation to the heart so that the ion channels that we hypothesized, were not able to adequately form so that they had proper repolarization. So even though they had no long QT, the usual type of scenario that people think about with repolarization, they had abnormal repolarization. And when we did studies looking at the morphology of the T waves, they were abnormal. So there's a lot of things going on and a lot of complexity because these dogs also will outgrow their arrhythmia. The mechanism for that, we do not know. We know that they never did innervate. They stayed with a lack of innervation. And it's also very important to know that the arrhythmias, we would not see them when they were 4 or 5 years old. If they make it past 2 years of age, they all lived a normal life.
And that's just fascinating, isn't
Yeah,
it? For
that's
something
very cool.
that's so malignant and carries such a high risk of sudden cardiac death. Why are some of these dogs the lucky ones? You know, who bought that lottery ticket that allowed them to grow out of this arrhythmia? Do you have any feeling for whether the ones who make it through to age 2 or 3, do they have any longer term consequences? Do they have a higher risk of arrhythmiogenesis in the future? Or...
No, I would often say if they don't die, they're going to live. And they never had any problems. They don't have abnormal echoes. They're fine.
Wow.
That's so interesting. The natural history is so interesting. How can you have so malignant, nasty arrhythmias? And then again, if you are lucky enough and you live beyond 2 years, then you are fine. Is there any human disease similar to what you have seen in German Shepherd dogs? Is there any condition in humans with a similar natural history?
Not exactly. I could list 3 or 4 that have some of the characteristics, but none of them really pigeonholed in with these dogs. It's not like the boxers with ARVC, and there wasn't some whole commonality to the situation.
Can you tell us how do you approach this case in the clinic? So, as you said, we will need 24 hours halters to fully assess these patients and understand if they have malignant arrhythmias during sleep. But then, for example, what are your criteria to start treatment? Which cases, which criteria do you have on the halter to predict the risk of sudden death?
If a dog does not have any ventricular tachycardia, I did not treat them. If the dog had non-sustained runs of VTach, then you can consider treating them. The problem is, like if I'm treating a boxer and he's got a lot of arrhythmias, I will set a high standard because of variability day to day to say that the antiarrhythmic was successful. And that means it's got to have an 85 to 95% reduction in the ventricular arrhythmias and the VT. Very high standard. You're never going to reach that kind of standard with the German Shepherd. We can find a statistically significant reduction in the number and severity of arrhythmias when they are treated with sotalol and mixilotine. You do not treat them with sotalol alone. That will make the arrhythmia worse. It must be given with mixilotine.
And that's because of lowering the heart rate, right?
Yes, but there are other mechanisms with regards to the repolarization reserve as well, because it's an IKR blocker, sotalol is, and with the slower heart rate. So you're going to expose the heart to a longer repolarization time, which is going to potentiate the EADs. So that is one avenue that can be taken. The ICDs have not been successful because they're not geared. There's a lot of things that we could talk about there relative to them not being programmable for a dog's heart rate, which is much faster. The T wave in a normal dog gets taller with high heart rates, and so it can be misinterpreted by the ICD as ventricular fibrillation, and a dog can be shocked. So it's very complicated. So we do try and monitor, and we do see a reduction in the number of arrhythmias. So what we do is we will treat them, hoping that we don't get side effects because you're more likely to get it with this combo, and we recheck the halters. When the dog gets to be around a year to 18 months of age, that is when most of the dogs can be taken off of the medication. We stop the medication and do a halter in about a week. And if we see VT coming back and we had it under control, then we'll put the dog back on the medication. If there's just some PVCs but no VTach, we will just then recheck that dog's halter and say 3 months and see what he's doing. As long as they don't have VT, it's phenomenal how well they'll do. Now, with these dogs, one of the reasons they do well is because they have a normal functioning and structure of their heart. And so when you have normal structure and normal function, you can tolerate, and youth, you have all 3 of those things, you can tolerate a lot. It's not the same as with other arrhythmias that we treat in other dogs. We can be much more relaxed. In fact, I saw so many German Shepherds with so many arrhythmias. I for better or worse, I became relaxed about some of the ventricular arrhythmias because they could be so bad, but they'd never seem to mind. But again, that's specific to the German Shepherd. But I will tell you, if that dog had VT, I was not relaxed. It was just when they had premature ventricular complexes.
Right. I think we forget how much substrate and how many different substrates for arrhythmogenesis there are in those dogs with cardiomyopathy, myocarditis, fibrofatty infiltration. There's so much more going on, isn't there, that can make the landscape so much more complex.
Yes, and I think some of the things that are being found in humans with ARVC, as well as what we're beginning to understand more with boxers, is that in boxers, you can get a lot of arrhythmias before we recognize any structural abnormalities. Now, of course, the boxer does have structural abnormality, even though we may not see it on an echo, because we know that the desmosomes are altered. We know that they're gap junctions. There's a lot of abnormalities that are happening, but their echoes look fine. And there's a lot of calcium dysregulation in the boxers as well. And this is what is also seen in humans and in the mouse model of ARVC. And so you can get a lot of arrhythmias without having the type of reentrant arrhythmia that we might first associate with the structural abnormalities in the ARVC. And some of these initial ones, due to calcium dysregulation, are interfering again with repolarization. But in the boxer, it may be that it's more DADs than EADs, although both can happen. And this is why they've found in the mouse model, and they're using it in some people that have ARVC, that have the arrhythmias before you see the structural, they're using drugs that are going to have an effect on the ryanodine receptors to control these DADs, like flecainide. And this is one of the things that perhaps we need to really look at in some of these cases in the boxer, particularly in the early stages, because you can have some of these boxers, you don't know which ones are going to go bad early and which ones are going to go bad in 10 years. I just got finished reviewing a Holter series on a boxer that 2 years had just so much ventricular tachycardia. Unbelievable. And the dog lived to be 10 years of age. Just really monitoring him, treating him with sotalol, then adding mixilotine and keeping a close eye on him. So there's a lot, so much to learn about these arrhythmias and these individual dogs and the individual abnormalities.
Right.
Do you have any ideas of why there is so much phenotypic heterogeneity? Because that's true for the German Shepherd dogs, German Shepherds, and also for the boxers, as you are saying. We see boxers with very nasty arrhythmias, lots of PVCs, ventricular tachycardia that will remain stable for many years, while others will progress and will suffer sudden cardiac death. Do you think, are there any epigenetic factors involved, or do we know why is there so much phenotypic heterogeneity in these arrhythmic cases?
I think this is a very important question. This is a question that comes up for probably every disease on the planet, the variability. And it's the epigenetics, it's the environment, it's other genes that are involved, the modulating factors, triggers. There are so many triggers for arrhythmias. And so I think this is a very important thing. Inflammation. I mean, in ARVC, inflammation is a biggie with regards to a trigger. With the German Shepherds, we've talked about the sleep and having times when you have the high sympathetic as well. So, and the truth is that sometimes we cannot get rid of the substrate, but you can treat the trigger. And that's why so often we will see a response in boxers when we are treating them with sotalol, because we are getting that beta blocking effect in there in concert with an antiarrhythmic effect, also to soften the trigger of the sympathetic system.
Just thinking about, well, I've got two questions, actually, both very different from one another. So forgive the change of tack. The first question is, I'd love to hear your thoughts on the auto antibodies that are reported in boxer dogs with ARVC. I think it's a super interesting topic, but maybe one that is of no clinical relevance. But I'd love to hear your thoughts on that. And the second question is about interventional management for some refractory arrhythmias. Would you ever think about ablation for dogs who've got these marked substrate changes, for example, in ARVC?
There is so much now that we're learning about the role of the immune system in multiple different diseases. In humans, for probably, like 20 years, the immunologic influence on ARVC has been sought in research for quite a while. And then there's the triggers that might bring that about, just like with viral infections. So I think that we're just at the very tip of the iceberg there. One of the problems with regards to the interventional treatment is that you've got to have an animal that is of adequate size. Now, fortunately, a boxer is of adequate size. The other thing is that we have to know, where are these arrhythmias coming from? And are they coming from multiple spots? For example, where are they coming from? Well, certainly with mapping, you could find that out. However, what if it's coming from the epicardium and not the endocardium? Then that becomes a much more complex situation. And then with the interventions to control these arrhythmias, even though, like in very specific situations, you can absolutely have a very positive influence. The best example, of course, is with accessory pathways to curing the animal. When you have some of these arrhythmias where you've got disease in multiple places in the heart, and they could be in endocardium, epicardium, all over, then trying to ablate those regions may be very problematic. I'm not saying that we shouldn't try it, maybe, and of all the different things that are under development, there can be new developments in technology that will permit finding the sites and doing that. But I think we're a long way away in making that the standard of treatment.
Yeah, absolutely.
Still regarding intervention and treatment, if I remember right, your group, you have tried to pace dogs with German Shepherds with inherited ventricular arrhythmias, which I thought was a very, very good idea. So if these dogs, we are saying that they would develop the arrhythmias when they have pauses and they are bradycardic, if you would implant an artificial pacemaker and pace them at a heart rate, I believe above 120, 130 was what your team did, then we would potentially avoid those arrhythmias. Can you remind us what was the outcome with those cases? Did pace improve the ventricular arrhythmias or reduce the risk of sudden death in these dogs?
By pacing the dogs, we absolutely got a significant drop in the number or frequency of the arrhythmias. However, they could still have breakthroughs of their ventricular tachycardia, and we still had sudden death in those animals. The other thing is that although we think of early after depolarizations as being pause dependent, it is not exclusively like that. I still saw rapid ventricular polymorphic ventricular tachycardia when there was no pause, particularly the younger the dog is. But you do need to remember, too, that there is kind of a sweet spot of recognition. Like if you examine most of these German Shepherds, say when they're 3 months old, you're not going to find any arrhythmias because their heart rate is fast and they're in a situation where their repolarization reserve is still adequate for the rate that they're under. So when they start to show the arrhythmias is usually around 4 months of age. It depends, again, there's variability, but that's when it would happen. But so does pacing help? Maybe. Is it an absolute? No.
It's sad, isn't it? Because it's such an elegant solution. I love the
Yeah,
idea of,
Yes.
okay,
Exactly,
the
it'd be
pause is the
brilliant.
problem, so let's get rid of the pauses.
Exactly.
But
Exactly.
life's not so simple, is it?
Yeah.
No.
I would love just to ask one last question about ventricular arrhythmias, because just both you and I, Kieran, are so interested in troponin I and so on. I would love to hear
Oh, you
Sina's
stole my
opinion
question,
about.
but I discounted it. I took it out.
Oh, really?
No, you go for it. It's a great question.
So we are both very interested in troponin I, and frequently in our podcast we have discussed about cardiac biomarkers in different diseases, and we would love to hear from you. What was your experience with cardiac troponin I on these German shepherds? Was troponin I increased? Was there any relationship between troponin I and outcome? Do you have any data on troponin I and in these dogs?
Yes. They were always normal.
Oh, wow.
They were
Amazing.
always normal. Now,
Wow.
again, we're dealing with a young dog with a normal structured heart. It's not the same as a dog that's got myocarditis or ARVC and having it's just not the same. So it's not going to help you, other than it's going to help you know, or at least have some idea, if you were having myocarditis in this dog. And when you've got a young dog that has arrhythmias, that's a top differential is it myocarditis?
It makes sense, doesn't it, to use the troponin there as an exclusion test?
Yes. Well, it also depends on the stage of myocarditis, but it can be very helpful.
That's very interesting. So many times we have an increased troponin I, maybe not sky high, maybe not more than 2, 3, 5, not maybe just mild increase troponin I, let's say, and ventricular arrhythmias. And we end up discussing, can ventricular arrhythmias per se increase troponin I? And in my head, I thought always, well, if we have non-sustained VTAG, these will cause myocardial ischemia, perfusion abnormalities, and can, I thought, likely cause myocardial damage and death. But looking at German Shepherd dogs, if they have nasty long bouts of ventricular tachycardia and their troponin I is still normal, do you think? I think my question is: do you think just without structural heart disease, without myocarditis, a healthy myocardium, if you have ventricular tachycardia in a healthy myocardium, do you think troponin I would generally do not increase at all? So just arrhythmias would not cause an increase in troponin I?
I think it all depends on how fast the VT is and how long it goes. The faster and longer, then you can get secondary changes. But most of these dogs had non-sustained runs. So they did have ultrastructural changes in their mitochondria, indicating that they were affected. The changes were very similar to tachycardia-induced cardiomyopathy, but you never saw any gross structural changes. So again, it's how fast and how long. And the shepherds didn't have them long enough. They were fast, that's for sure. I mean, their heart rates would go 500 beats per minute, but it was never very long.
Wow.
Very interesting.
Sydney, when I think of you and your work, my mind goes to ambulatory ECG. Now, that's partly because you've been very supportive and helpful to me in the past in thinking about ambulatory ECG and how to approach embarking on analyzing that myself and reviewing Holters. So I really wanted to try and move on to talking about ambulatory ECG. Tell us a bit about how you became interested first in ambulatory ECGs and how it's changed how you work.
Okay. Having long-term electrocardiographic monitoring, I think, should be just a normal standard evaluation for almost all arrhythmias. If you're thinking of treating an arrhythmia, the dog needs a Holter. You've got to get a baseline in order to know if you've got a treatment response or if it's getting worse. That is a very basic approach. The other thing that I have learned is that there is so much to the rhythm of the heart that is missed by not looking at these long-term recordings. When you start looking at them and you look at them in different ways, you discover patterns. And these patterns can give you the data of observation to think about the triggers for the arrhythmias and the mechanisms. You can plot out 100,000 beats and look for the coupling intervals being the same or being different. You can plot out to see if the preceding RR interval is related to the coupling interval, whereby if it's a faster rate before, the coupling interval is shorter, indicating that it's a DAD ventricular response. And if you can see that, then you can be highly suspicious that drugs that may affect the mechanisms that cause delayed after depolarization, such as excessive calcium, you can start thinking about the drugs to treat. So there is so much there. This is why I'm doing the book on long-term electrocardiography, is there's a lot of excitement, of discovery that will give us some answers. And if it doesn't give us the answer, I guarantee you it's going to point us in the right direction. And I think having tools, and these tools, in my mind, are examination of a tachogram where you have the time of day and the beat-to-beat interval plotted, and making sure you look at a 3D plot. The Poincaré plot, where you have the beat-to-beat heart rate variability, where you have one interval plotted against the next, and then that one that was the next becomes the one that you then plot against the next. And these form, again, patterns. When you look at some of these patterns, you start to see that certain arrhythmias have a pattern. And if you can see it, that means you can teach it. And who are you teaching it to? AI, machine learning. And when you teach that, then you can easily, then in the future, we could have these Holters being read by machine learning and classify and see what kind of arrhythmia it is. I have actually been so surprised how I can look at these Poincaré plots and give you a high likelihood of what the diagnosis is. And I have never even looked at the beat. I'm not saying don't look at the heartbeats because you get a lot of information. I'm just saying that the vision that you see of the heart beating dynamically, that's what the heart does. It's a moving, beating structure. And to just look at a few still beats of wiggles on a paper or a screen is only the beginning of understanding an arrhythmia. So I think there's a lot of future in this way of examining the beating heart.
Can you just share with us, so if we'll give you a Holter report, what's your thought process? What are the first 2-3 things that you look at to have an idea about the case? How much do you focus on Poincaré plots? Because I guess most of us will not have Poincaré plots on the Holter recordings. Maybe we should. But can you guide us through your thought process? If you have a Holter, which are the 2-3 things that you want to look at first and to have an idea about the case?
Sure. The first thing you want to make sure of is if you're using one, of course, the editing has to be accurate. And so for me, to see if the editing is accurate, you can do 2 things. One, you can quickly page through the full disclosure, or you can look at the tachograms and see if they make sense of what premature beats would look like, a sinus arrhythmia would look like, and you can very quickly see about that editing. Most editing for most dogs that require a Holter takes time. That's why the machine learning, I think, is going to be extremely helpful for the future, because right now, the amount of time it takes to actually edit is too long.
It can be huge, can't it?
Yes, it's huge. So there has to be a better way. So that's what I do first. And then, because you've got to know if it's identifying the beats correctly. And you can do that because the beats are coded in color. And so you can tell whether or not it looks like you agree with what the machine has done, or what the person who's doing the editing for you, or if you're doing it, has done it correctly. And then you can look at the actual counts and the numbers when you're dealing with premature beats. If you're dealing with, say, atrial fibrillation, you can see by the pattern if that is correct. So there's a lot of different things that you can quickly look at to know if it's correct or not.
And once you've established you trust the data, does it depend on your suspicion or previous diagnosis of what's going on as to how you then walk through the rest of the data? Do you go straight to the tachogram? Do you start looking at pause length, things like this? I mean, I think we all have a protocol of how we look at the reports, but we'd love to hear about
Yes, I think if you've just got this report from somebody, you're going to be limited in what you can do.
Right.
When you have the actual ability to digitally move through the Holter recording and the data that's generated, it's going to be more informative. You also get a feel for what the dog's rhythm is. We always have a diary. We will check that to see what the animal was doing. If we see an area that was bad, we find out, well, what was the dog doing at that time, to know about triggers. I must say that you said, what do I do first? For me, the first thing I do is look at the tachogram, because I can tell very quickly if it's correctly edited, and I can tell with regards to premature beats. The other thing that's very important is that you have to understand when it is automated in the report that you get. You need to double check the accuracy of that, because, for example, it may say longest pause 3.2 seconds, and you may go, oh, okay, well, and then it says that there were 10 pauses or whatever. That doesn't tell you that 3.2 second pause was then followed by another pause that was 3.1 seconds, another one that was 3.1 seconds, and so on and so on.
Right.
So that in actuality, you're not getting the full picture because you didn't see the secondary pauses.
Yeah.
And you may say, oh, well, wouldn't I get that information from looking at what the slowest rate was? Not necessarily, because you have to understand when the different companies calculate the average heart rate. That is a rolling average heart rate over 10 seconds for most of them. So if it doesn't reach a certain criteria, it's not going to calculate that. You have to understand where all of these algorithms have come in for the Holter analysis. And I can tell you another thing that goes on. No Holter company has a system that's great for dogs. And a lot of them have software that has had algorithms and programming and coding added on and added on and added on. So it becomes a conglomerate of the past, the near past, and the moment. And this is where I think that there's going to be a lot of changes happening very, very soon, with these being analyzed more accurately. with the machine learning. It's going to get better. I mean, just like you're able to now, just by the beat to beat processing, look at what kind of arrhythmias on some of these like Fitbits or different ways that are being developed for dogs too. So there's a lot coming in the very near future, I feel.
So you've mentioned the beat to beat intervals and variability. You've mentioned Poincaré plots. Earlier on, Jose alluded to your son being involved in some processing and analysis. Tell us a little bit about that and how that came about.
I always wanted more with the Poincaré plot than just this still picture. I wanted it to be in dynamic, and so that I could see it changing over time. And I knew that just looking at a two-dimensional also tachogram, that when you look at that, when you get the report, if you have an interval that's the same interval as another one, the dot's just placed on top of it. So you have really no idea how many there were. So wanted a three-dimensional idea of it. And so my son, Wyatt Flanders, what he did was he developed some programming that when you take the beat-to-beat intervals, and he can take it with the annotation of being, say, ventricular or supraventricular, and then he can make it so you can have the Poincaré plots in 3D, you can have them animated, you can select the time you want. It's not just 24 hours or 1 hour at a time. You can, if the diary of the from the owner says that the dog was doing something and something happened, you can select that time and really dissect what was happening that made that arrhythmia come about. Because again, sometimes you can eliminate the trigger. And then what is happening now is that we're trying to be very specific with regards to understanding some of the observations. And I think this is where I think some of the most exciting things about being a veterinarian, a clinical veterinarian, are. And that is, we are the first observers. And it's very important that if you observe something and you see it happen again and again, there's meaning to it. And then you need to figure out, what does that mean? And so having my son helped me to figure out what the observations were meaning. For example, we recently published a paper on sinus node dysfunction. And sinus node dysfunction has multiple reasons for it to occur. And it really looked to my eye like there was an integer relationship in some of these dogs between one beat and another. And so Wyatt developed a program where we compared dogs that had high vagal tone, that all had heart rates less than 60, and dogs that had sinus node dysfunction due to hypothesized exit block. Because this would, with the exit block, that would give you this integer relationship between each of the beats.
Yeah.
And so he used machine learning to train with one set of data, dogs that just had high parasympathetic tone, and then dogs that had sinus node dysfunction, but had similar heart rates. And then we had a test set. And it was amazing how accurate it was. And then we discovered that there were actually two types of sinus node dysfunction due to exit block. It's a little bit more than we can go into right now, but it was indicating to us that there is a different mechanism in these different dogs. And you might say, well, what difference does that make? Well, it might make a big difference in how we might pace them, what the prognosis is, why they're having it. And what we discovered is that some of these dogs would have fast rates, but they would get very slow suddenly, but they did it in multiple or integer ways, so that in fact, these dogs had a tachyarrhythmia masquerading as a bradyarrhythmia because they were still having a sinus node reentrant type of tachycardia, but it was blocking. So in the end, on the ECG, you saw bradycardia, but the underlying mechanism was really a tachycardia. So obviously, this could mean a big difference in the way you treat them.
That's very, very cool.
Oh, it's fascinating, isn't it?
Yeah, it's fascinating. And that work of yours, indeed, to show that examining the Poincaré plots with machine learning, you could differentiate between dogs with a hypersympathetic tone or hypersympathetic modulation versus sick sinus syndrome or sinus node dysfunction is indeed fascinating.
My greatest joy in doing all this has been to get to work with my son. Wyatt.
So what is his background? He
got his degree in physics. He got his degree in physics, and then he just taught himself coding.
Wow.
Yeah.
Wow. Amazing.
Smart guy, huh?
Can I just ask you, because clinically, a lot of times we have patients which on ECG or Holter would classify as sinus node dysfunction, but then they would also have systemic diseases which may increase the parasympathetic tone. Central nervous system disease, ocular disease, respiratory disease, GI disease. And then clinically it's difficult to understand, are these ECG findings, are these conditions with hypersympathetic tone just unmasking an underlying sinus node dysfunction, or where is the line? Where is the line between an extreme abnormal hypersympathetic tone versus early sinus node dysfunction?
The line is a very big, wide ribbon. It's not just a thin line. And it comes into the complexity of the disease. Sinus node dysfunction can be because you have exit block out of the sinoatrial pathways, because to get to the atria, it's not just like a line surrounding the sinus node and it's just like a wave that goes through. There are actually these portals, so to speak, these pathways to doing this. So if you have sinus node dysfunction, it could be that there is a block in that pathway. It could also be an oscillator problem. In other words, the pacing cells are not pacing as fast as they should be. Or it could be a tachycardia reentry arrhythmia within the sinus node, or going a macro reentry going through the exit pathway and back into the sinus node. So there, as well as you can have sinus node dysfunction due to abnormalities of the autonomic nervous system. So there's a lot of overlay in these abnormalities. Add in the factor of age, because with age, there is going to be a decrease in the number of pacing cells. You're going to have more fibrofatty infiltrate, and you're going to have more blockage. So it is a complex situation. And so with each one, you have to dissect out exactly which is the biggest problem, because not every dog with sinus node dysfunction needs or should have a pacemaker. But we look at the severity of the pauses, how many pauses they have. That was another thing that's very discerning, is the number of pauses is very discerning between the high parasympathetic tone and one with sinus node dysfunction.
And response to atropine. So we will give atropine to these dogs to see if they respond to atropine. And if there is a positive response to atropine, we may say, okay, these bradyarrhythmia pauses are vaguely induced. How correct is that? Are there cases out there where they still respond to atropine, but there's underlying there is sinus node dysfunction? How do you detect them?
Absolutely. Most sinus node dysfunction dogs are going to respond to atropine to some degree. And I don't necessarily hang everything on an atropine response test. I also think that there are these subset of dogs that I talked to you about that we discovered that have an underlying probability of a tachycardia masquerading as a bradycardia. So then you give atropine. Because have you ever had one where you gave the atropine and they went really fast and then all of a sudden they stopped? This can happen. The other thing is that when we look at more and more dogs and look at the patterns that we see of the vagal dog versus a sinus node dysfunction dog, I think it's going to become clearer and clearer. When Wyatt wrote the program for the machine and doing the machine learning, it was amazing how accurate it was in discerning the parasympathetic dogs from the sinus node dysfunction dogs. And I think that as all of us work together and we train on, more than, what we did, 25 dogs in each group, when we start to get to hundreds, it's going to become clearer and clearer. I do think that with, for example, the machine learning with arrhythmias and things, in our case, it's going to likely be that we need to go rhythm by rhythm. It's not going to be some big global process at this time, of making a diagnosis. We need to first train on the absolute data of here's a group that have this rhythm, train the machine learning, and then do the testing and grow it. And then it's kind of like building a library of the ability to really see this. And I think it's like right now, Wyatt is working on a program to identify delta waves and the vectors in order to determine the axis for pre-excitation, like where in general the accessory pathway is based on the machine learning. So there are so many different things that could be done. It's extremely exciting. There is a real need for people who are interested in discovery and investigation to learn about AI, machine learning, so that then they know enough to collaborate with those who can do the actual programming and develop the models that we need to make the diagnosis and use it in concert with what we're doing. For example, if you have a question and you're thinking about what that dog is, and then you upload the intervals to the website, which is open access, that Wyatt's developed, you can then, within 1 to 2 seconds, see if it agrees or disagrees with you to get some idea.
We're on the brink of this amazing era, I think, in diagnostics. I feel like, as you say, we all need to learn just a little bit more about it. Otherwise, we're going to rapidly become dinosaurs, and all these diagnostics are going to move on without us, and we're going to lose that understanding of what's happening, and therefore lose the quality control, or that sense of quality control we have right now, because we understand the diagnostics we're doing.
Yeah, I think you are absolutely right. I mean, in the curriculum, they need to right away put training in place so that veterinary students understand, because it's not just in cardiology, it's going to be in everything.
Yeah.
And that people must be informed so they know how to use it, how to know if it's wrong, because we've always got to be able to think. We cannot give up thinking.
Right.
And there's always going to be new discovery of observations that are made that need to be tested, and people need to be aware about how important it is taking an observation, moving forward on it to prove or disprove or uncover things you didn't even know about. It's in a very exciting time to be in your 20s.
Too late for us.
I'm going to hang up my hat now. I think it's interesting because you've sort of alluded to how, or really you've talked about how in your data set there on the sinus node dysfunction dogs, looking at the machine learning output was hypothesis generating. to say, oh, hey, look, I think we have two sets of dogs here. And then you've looked into that and evaluated further to understand it. And there's a huge place for that in research, isn't there? Is actually taking just the raw data and the machine telling us, oh, there's something here. This is where you want to focus your efforts, focus your research funding. So maybe this is something we're going to see more and more over the next 3-5 years.
Yes, and the machine learning, it may not tell you that there's a difference. It may give you the data you look at, and because of the way that it's able to present it, you see it.
Right.
You recognize it.
Right.
I think that's another very important part of training, is for people to be to be excellent observers. Because don't just go get the blood and get the lab work. Observe the patient, ask the questions, and look at the data carefully. We've all been to physicians who we wished had looked a little bit closer, done good physicals, thought, and at first you've got to notice things. You've got to pay attention first.
See, and if we look into the future, and if we talk about machine learning and so on, where do you think we are heading? Where do you think there will be major breakthroughs in veterinary arrhythmology in dogs and cats? What are your predictions?
Oh, wow. I think, and it's going to be through my lens, I think that we're going to be able to make diagnoses faster. We're going to be able to subclassify better. It will not be adequate to say, oh, it's VTAC. It's going to go beyond description. Oh, it's non-sustained, or oh, it's monomorphic. It's going to go more mechanistically. And I think that that's very important. And I think we may not be able to get to the mechanism, but if we get enough observations and of characteristics and follow enough patients, things may fall into place with regards to what it is that will pinpoint more to the treatment. Think about it. When we go to treat VTAC, if you ask 10 different people, you're going to get at least 5 different answers. And then you know what happens? It ends up that we trial and error drugs to see which one works and which one doesn't have side effects. Now, on the other hand, there are cases where after a while we start learning which particular dogs with what particular diseases actually respond to the different drugs. And this is true for very specific diseases, but it may be that there is a rhythm classification that may come about that will help direct us more to a specific drug. In other words, we may not get to the mechanism, but we may get so many phenotypic clues that cluster together.
Right.
Then they fall into a pattern of the treatment, and we look at that response. And this is where I think also people need to follow up. If you're going to use an antiarrhythmic, you got to know if you made it better or not.
Yeah, and I guess using that same logic, that'll be particularly important for the patients that are atypical. So not the Doberman that walks in looking like it's got cardiomyopathy, or the boxer dog that walks in with ventricular tachycardia, but actually the, 1.5-year-old Italian Spinoni, who looks different to the others and may not have the same echo findings and has a normal troponin. If the analysis system we're using in the future puts them in the same cluster as a bunch of dogs we really understand, maybe then we don't need to know the exact mechanism, but we can get a feel for how that individual may respond to
exactly.
I like that idea. That sounds great.
Yeah.
Bring it on. Bring it on.
Because we may not be able to cure. Most of the time we're not able to cure the substrate, but we can so often find an avenue by getting to the triggers. or understanding that association of the patterning with a certain type of mechanism, therefore we can choose the drug, even though they may have still the underlying disease. Amazing
stuff. I'm always the guy with my eyes on the clock in these conversations. And I feel guilty about that because I'd like to carry on talking about arrhythmias, but I'm mindful of where you are, Sydney. It's getting on reasonably late as well. A lot of stuff to think about there, and a lot of inspiration for us, I think, and our listeners to go out there and become better observers as a starting point for this. Professor Möise, it's not enough for me to say thanks for joining us. We've been honoured and inspired by our conversation with you. Thank you so much for joining us on the Animal Heartbeat.
It has been my pleasure. It's been a lot of fun, and thank you so much for inviting me.
Thank you very much indeed. It was truly a pleasure. Brilliant.
Thanks, y'all. It was so nice to see you.
You have been listening to the Animal Heartbeat. Thanks very much for our listeners.
Keep in touch by finding us on social media or sending us an email on animalheartbeat@gmail.com. Please remember to like, follow, and share to help us find new listeners. And make sure to check out our previous episodes wherever you get your podcasts from or on our YouTube channel.